super lucky to have the executive director of Rhode Island's Department of Health, Anna Noves. Did I say it correctly? Okay. She has a master's degree in clinical psychology, and she's worked in the field of public health for over 30 years, including 5 years in Africa and 5 years in Portugal. She's worked for the Rhode Island Department of Health since 1998, first as an education and outreach coordinator focusing on children's health issues, specifically lead poisoning prevention and immunization. Immunization, hot topic right now. Later on, she was the chief for the Office of Minority Health, charged with addressing the health needs of the racial and ethnic minority communities of Rhode Island. Now, as executive director and also deputy director, she leads efforts on disparities and access to care and environmental health and maternal and child health. So, very relevant to a lot of the conversations we're having in the state right now. So please join me in welcoming her as well.
What I wanted to do tonight was not talk about the specific legislation, but from a public health perspective, the work that we're doing in terms of assuring that all women and all children and all Rhode Islanders by default have the appropriate care and the appropriate rights in place as it relates to health care. So as a Department of Health, and I've been at the department for many years now, over 20 years, from the get-go we've always had a lens in terms of social justice and that we put to the work that we do. We use that lens of social justice and human rights as a guiding framework for the work of the health department across the board. And I think in terms of probably there's no area where that becomes more evident than in women's health and in children's health issues. So we have three leading priorities that guide the work that we do. We are striving to address the social and environmental determinants of health. We are making sure that we eliminate racial and ethnic disparities, but also any other disparities in health outcomes. We are striving to achieve health equity for all in Rhode Island. And we are trying to assure the quality of the health services, that everyone has access to quality health services, particularly our most vulnerable population. And when we think about those three leading priorities, if you talk about the first one, we are talking about things that are fancy words, but to talk about education, about right of unemployment, of having not just minimum wages, but a job, being fully a job that allows you to do more than just survive. Having an education that allows you to leads you to that good job, and to have then insurance and have proper access to care. We're talking about the health system that is beyond the healthcare system as we know it, the traditional clinical care that you receive in a hospital, in a care center. We are talking about a system, a continuous system of care that includes community services, spaces such as this one where we are, that are part of that continuum of care. So it's not just taking care of someone, but then someone is sick, but assuring that we maintain someone's healthy. And that means really getting engaged across that continuum. But when we talk about women and children, and in terms of reproductive health, that is one of our main priorities and one of the core responsibilities that we see that we need to respond to. So when we think about in Rhode Island, 36% of pregnancies in Rhode Island are unintended. And unintended meaning either that they were mistimed or they were unwanted, if we can use that word. And that has consequences. When you have that number of unintended pregnancies, there are consequences for the health of the mother, for the health of that child, for the health of the family in general. So how do we work with such data in order to improve and assure that we do have good health outcomes? When you look also, and when I think 36%, but if you use a lens of disparities and you use this lens of social justice and you try to look a little deeper in that data, you can see, for example, and this is not surprising, that for women who are under the age of 19, 82.8% of those pregnancies were unintended, versus 29.7% for women over 30. So there is something about age, not surprising, in terms of planning, timing, or even wanting a pregnancy. When we look at Black, non-Hispanic women, there are 60.6% of them reporting that their pregnancy was unintended, versus 47.8% for Hispanics and 36.5% for whites. There are also disparities in terms of education. So for folks with less than a high school diploma, there's 57.2% that report their pregnancy as being unintended. While for folks with a high school diploma and higher, that number drops down to 34.2%. So those are statistics, but they are realities. Those are the folks that we know, your neighbors, my neighbors, someone's daughter, someone's uncle, mother, people who made or did not have the opportunity to make a decision. People who found themselves in circumstances that then felt that they didn't have an option or options put in place to make those decisions. And that's the lens that we try to use in public health. How do we offer folks a comprehensive array of services that allows them to make the choices that they want to make? That's the lens that we've been using, of reproductive justice, of the right to make decisions about being sexually active or not, about having children or not, the right to how you want to raise your children, how you want to take care, the birth rights, meaning how do I want to be taken care of from a preconception health care, how do I want to be taken care of from a pregnancy perspective, during prenatal care, how do I want to give birth, and what kind of post-care, postpartum does one want. Those are issues that we need to incorporate in public health if we truly want to serve people, all people, in a way that feels respectful and that feels acceptable of their own needs, desires, and rights. When you think about one of the biggest disparity that we saw, the 60.6% of Black women, there is this narrative going on within our Black community that feels that their encounters with the health system have been, in most of the time and during pregnancy, almost like a battle, where they feel disrespected, where they feel they weren't listened to, and where they feel that the service, the system of care that we have right now is not responding to those needs. A reclaiming of old traditions, of nurturing mom as well as the child, of recognizing that after you give birth, you still exist as a person and not just turning attention to that baby. Or a system that recognizes that you don't necessarily, you may not want to have those children. And how do you continue to feel listened to, respected, and not questioned in the options that you're doing or not doing? And then in a system that recognizes that sexual oppression is a reality for many women and many men. And so how do we create a system of care that is responsive to those realities? That's the lens that we are using in the work that we do. And that's the work that we try to do at the Department of Health by engaging with communities, by bringing all folks into the table, and by truly recognizing that we do not know it all in public health. We may pretend that we do, or we may think that we do, but we don't. And so being able to step back, listen to the community, listen to the people that you're trying to serve, and fully, respectfully incorporate that feedback, it's a critical component of the work that we do. And one way that we've tried to show that in very practical terms, even outside of reproductive health issues, it's through an initiative that we call health equity zones. And those health equity zones are neighborhoods that are coming together, residents, key stakeholders in their neighborhoods. Thunder Mist is leading one of those community-led collaboratives where we support communities coming together, doing needs assessment, making determinations about what help means to them, what issues are important for their community to be addressed, and then we help them with funding to support the implementation of community-led plans of action. And we are funding things that have to do with domestic violence, that have to do with community and police relationships, job training, seniors engagement, all kind of things. What we are not necessarily doing in those communities is having an obesity prevention program, telling people how many minutes they should walk, physical activity, how many fruits and vegetables they should eat. It's really shifting the lens of how you do your work. And it's embracing that we have tremendous amount of knowledge in our communities, in the residents that we serve, and being willing to step back from it and say to the community, you know better. That lens, it's the same lens we bring to the work of reproductive health. And it's saying to our women that we serve, to the girls that we serve, to the families that we serve, you have a voice. You need to let us know where it is that we are not going, where are the trajectories that we need to pay attention, what are the types of services that we need to put in place. So at the end of the day, everyone feels respected in that encounter that they have. And everyone feels respected in the choices that they make. And that everyone, as they engage in the healthcare system, feels valued, feels heard, and feels most importantly served in whatever way is the right way for them. That's what we see our work. That's where we see an alignment with what you are doing from a legislative perspective, what our senators and representatives are putting forward as legislation, and the work that Thunder Mist is doing around trans health. Those are ways that as a state you can be rigid or you can be flexible. And hopefully we are being flexible and respectful of the people we serve. So thank you.
Thank you.